Okay, welcome everyone. Welcome to the first Liverpool Dementia and Aging Research Forum of 2022. And in this forum, we've got a very interesting talk as usual, but we have a special guest today. We've got Dr. Aida Suarez Gonzalez, and I hope I pronounced that correctly. She is a clinical neuropsychologist and researcher at UCL with a specialism in the diagnosis of rarer dementia subtypes. So today, she'll be telling us more about different dementia subtypes and how they can be diagnosed and maybe also how they can be treated. So throughout the talk, please post your questions in the Q&A box. We'll pick them up afterwards and discuss them. And also, if you are on social media, if you are on Twitter, please feel free to use the hashtag Liverpool Dementia because we'll also run parallel Q&As there. Without further ado, over to Aida. Welcome.
Hi, thank you very much, Clarissa. Can everyone see my slides? Yes, perfect. Okay, so hello everyone. Thank you, Clarissa, for inviting me to give this talk, and it is really a pleasure to share this space with you and with all the people attending the webinar, and congratulations for creating this fantastic forum. So, as Clarissa said, I'm a neuropsychologist. I work as a researcher, but also in clinical practice, and both in my research and my clinical practice, I'm very focused on rehabilitation approaches and therapies for people living with dementia in general and non-memory-led dementias in particular. So during the next minutes, what I would like to do is to tell you more about non-memory-led dementias, what therapy and support is available for them, and I will finish with a mention to the organization Rare Dementia Support. So, we talk about non-memory-led dementias or rare dementias. I prefer to call them non-memory-led dementias. And we talk about them to refer to a group of phenotypes, a group of dementias that manifest with a core symptom that it is not memory. Let's first remember the canonical presentation of a memory-led dementia. It is a person in his or her late 60s or older who becomes forgetful, forgets where he's placed the keys, the glasses, the wallet, whether he's paid the bills, asks the same questions over and over again and repeats conversations and shows partial awareness of these deficits. So this is the classic presentation of Alzheimer's disease, which is the canonical type of a memory-led dementia, and Alzheimer's disease is the most frequent of all dementias. It counts for around 75% of all cases of dementia, but there are also others, and they present differently. And I'm not going to touch on to all of them, but I would like to give a close overlook to 4 phenotypes that present with a clinical profile very, very different from Alzheimer's disease. So let me start telling you about dementia with Lewy bodies, which is the most common type of dementia after Alzheimer's disease, accounting for around 20% of all cases of dementia. So, how is DLB different from Alzheimer's disease? This is a typical case of DLB. This is Adam. Adam is a person in his 70s, and Adam has visual hallucinations. He's started seeing shadows of animals and little children hiding behind the curtains, and he's aware that this is not real. So he has very good awareness of these visual hallucinations. And he shows Parkinsonian symptoms. He shows rigidity, and he feels his movements are becoming slower. And these are landmark features of dementia with Lewy bodies. And yes, it's true, he's a bit forgetful, it's true, but the symptoms that dominate his clinical picture are the visual hallucinations and the Parkinsonian features. The majority of people with DLB also show REM sleep behavior, which is an abnormal behavior during sleep, and it is characterized by very vivid dreams where the person shouts out and acts out and with punching and kicking, and it is quite disturbing both for the person and for the partner or the person who is also sleeping in the same bed. So this is a profile very different of Alzheimer's disease, with also different therapeutical implications and a different prognosis. This is DLB, second most common form of dementia, main symptom, not memory. And I'd like to introduce now the subfamily of frontotemporal dementias. Between 5 to 10% of all dementia cases are due to frontotemporal dementia, and I'm going to tell you about one type of FTD now, which is the behavioral variant, and I tell you about a different type later. So, behavioral variant FTD and its peculiar starting symptoms. How is this very different from Alzheimer's disease? I introduce you to Julia. Julia has behavioral variant FTD, and Julia is young. So look at how young Julia is. She's 51. That is very different to the other cases that we've just seen. And Julia has started acting strangely. She started neglecting her parents. And she used to be really nice, but now she's a bit rude and insensitive, and that is very not her. She laughed at her friend's funeral, and her relationship with food has changed. She eats lots of sweets now and candy, and sometimes she eats ice cream for breakfast, lunch, and dinner. And Julia is completely unaware of these changes, and she doesn't seem to care. Julia shows the clinical criteria for behavioral variant FTD, which typically affects young people. Not always, but the majority of people are in their 40s and 60s when they develop the first symptoms of the disease, and it is characterized by changes in behavior and social cognition. Hyperorality, which means eating a lot, and lack of inhibition and lack of empathy, like connecting with other people's feelings. It is very, very common in people with behavioral variant FTD. And they also experience a progressive loss of what we call executive function, ability to organize and make decisions. So this is a pretty marked behavioral impairment, and this is very characteristic of behavioral variant FTD. But within the umbrella of FTD, we have two primary progressive aphasias. Primary progressive aphasia can be produced by FTD pathology, and these cases are usually expressed clinically as the non-fluent variant PPA and the semantic variant PPA. But there is a third type of PPA, usually produced by Alzheimer's disease pathology, and which is called the logopenic variant PPA. And these three variants constitute the three subtypes of PPA that we currently know and are identified and have clear clinical profiles and clinical diagnostic criteria. So what's exactly this thing of PPA? It is a type of dementia that starts with language difficulties. Sorry. So this is Susan. Susan has PPA. She's 57, because PPA also affects young people, not always, but many people with PPA start at a young age. And starting the profile always starts with word finding difficulties that become worse and worse. And new features emerge as time passes, features like speech sound errors or difficulties with articulation or with the meaning of words and things. And in the primary progressive aphasias, the language is the core symptom and the one that causes disability in daily living. Memory is usually preserved or mildly impaired. Sometimes it is impaired, but definitely the dominant symptom is language. The level of attentional impairment may also be variable, but what really limits the person in her daily life is language. And I said before that we have 3 subtypes of PPA. They all show language difficulties as the main symptom, but they are different language difficulties. For instance, this is the logopenic variant that shows pauses in the speech due to word finding difficulties and makes some sound errors, like saying tap instead of cap. This is very characteristic of logopenic PPA. The non-fluent variant is different because they also, it is true that they also change sounds, but because they cannot articulate well the word they want to say. So I'm not going to reproduce the sound of golf mispronounced because with my Spanish accent I will ruin the dramatic effect, but this is just to illustrate that people with non-fluent variant also show a more effortful speech, like it is more difficult to articulate, and they make grammar mistakes, which is placing words in the wrong order. And the less frequent of the 3 variants is the semantic variant. And this is a very peculiar syndrome, very peculiar, because it is characterized by a progressive loss of knowledge for the meaning of words and the things that those words represent. So it is a progressive loss of conceptual knowledge. And I will always remember one of the first people with semantic PPA that I treated. We were in clinic in a hospital, and there was a courtyard with trees and grass and stuff out there. And she pointed out to the trees and said to me, you see those green things out there? I don't know what they are. And I know I should know what they are, but I know I'm not able, I'm no longer able to recognize the meaning of those green things out there. And that experience, I think, illustrates very well what's the semantic problem of someone with PPA that is not only unable to retrieve the word tree, but also unable to understand what a tree is when it is in front of her. And the last phenotype that I'm going to discuss today, one to which I've devoted many years of research, is posterior cortical atrophy, or PCA, which is very infrequent. It is around 5% of all cases seen in a cognitive disorders clinic. And PCA is also called the visual variant of Alzheimer's disease. And this is how it looks like. John has PCA. He's also young. When he reads, the lines mix together, jumbling. His driving is worse because he cannot calculate distances and he hits the curb often when parking his car. And he has started having issues telling apart the front and the back of his clothes. His clinical picture is typical of PCA, and it is characterized by this progressive disabling visual loss and other functions depending on posterior areas of the brain, like for instance, apraxia, in particular dressing apraxia, which is this difficulty to put on his clothes right. Very characteristic as well, the geographical disorientation, which is basically getting lost in the street. And it is also very common in PCA that we see some signs of Gerstmann syndrome. Gerstmann syndrome is made of 4 main symptoms, which is digital agnosia, which is the inability to identify the fingers in your hand, difficulties with writing and calculation, and left-right disorientation. So you cannot distinguish left from right. So it is quite a complex syndrome affecting the posterior areas of the brain. And now, these 4 different types of dementia that start with these very peculiar symptoms, language and vision and behavior and visual hallucinations and Parkinsonism, why does this happen? What causes these types of dementia? These dementias are caused by aberrant aggregation of proteins in the brain. So if you take a piece of the brain of someone with PCA and look at it with a microscope, after the pathologist has prepared the tissue, you will see the pathology characteristic of Alzheimer's disease in most cases. And these are amyloid plaques and neurofibrillary tangles. In FTD, the disease is usually driven by aggregation of a type of protein called tau or TDP43 or FAS. And you can see here how they look like. And in DLB, the pathological findings are Lewy bodies. That's why the disease is called like that. And Lewy bodies are deposits of alpha-synuclein, a protein called alpha-synuclein. And these aberrant aggregations of proteins damage the brain, damage the tissue. It's not that these proteins are bad themselves. The original structure of the proteins is fine. We all have these proteins in our bodies. The problem is when they misfold and aggregate and become toxic for the brain, causing neuronal death and damage. Why the accumulation of this pathology produces these symptoms and not others? Because you may think, all right, so all these proteins, everything goes wrong, they aggregate, but why they are producing, in some cases, they are producing issues with language, while in others, issues with language, with vision, while in others, issues with behavior. So the difference is made by what part of the brain is more affected by this pathology. In the case of PCA, it is the posterior cortices. There is more pathological burden in the posterior part of the brain. In PPA, it's the language areas of the brain that get affected. And depending on the variant, I mean, if there is more affectation in the temporal pole, then you see the clinical the clinical profile of semantic PPA. If it is more in the Broca area, you see the non-fluent PPA features emerging. And if it is more posterior and more diffuse, you will see clinical symptoms of logopenic PPA. In the case of behavioral variant, it is the prefrontal cortex that gets more damage, and this is the part of the brain that rules our behavior and our executive functions. And in the case of DLB, the distribution of the pathology is quite diffuse, encroaching all brain. And some of you may be wondering, and why is the Parkinsonism? If this is diffuse, why these people have Parkinson as well? And that is because the basal ganglia also get affected. So this slide that you are seeing here is like a coronal view of this brain. If you draw a line here in the middle of the brain and you cut it out, and you can see what's here in these subcortical structures under the cortices. So they also get affected, and that's why these people with DLB also experience Parkinsonism. The reason why these proteins aggregate, concentrate all the burden in these places, in these different locations, it is something that we still don't understand why there is a preference for those specific areas, if they are particularly vulnerable, if there are genetic factors. This is something that we still don't know, but we know that the distribution of the pathological burden is responsible for the clinical picture. So people with these types of dementia have usually good insight into their symptoms, with the exception of the behavioral variant, and this makes them very collaborative patients for therapy and rehabilitation. And they are usually, in my experience, very engaging and very keen and very committed patients. And there are some symptomatic treatments for these conditions, but no disease-modifying drugs and no cure. So I would like to tell you about the non-pharmacological treatments and approaches that we have available. Something I would like to emphasize is that, being the fact that it is a progressive condition with no cure, many people think that there is little you can do when you live with dementia, and in particular, one of these less known types of dementia. So I really want, if you have to take away one message from today's talk, only one, I would like to be this, There are lots of non-pharmacological therapeutic options and support approaches that can make the whole of the difference in your life if you have one of these conditions. And let me give you an example. So for instance, I want to tell you about the power of training families in the management of behaviors that challenge and that the person cannot change. They don't do it on purpose. They don't have control over their symptoms, but both the person with dementia and the family can benefit massively from receiving training. Training is not providing information in a handout. It is working with the family to help them develop skills. And this work has a part that is education about the symptoms and another part that is putting well-validated and evidence-based techniques into practice. And I will give you an example of how we can help Henry using these techniques. Henry is this man here, and he lives with DLB. And Henry has delusions. Delusions are false beliefs that seem very real for the person, even when there is a strong evidence that they aren't. And around 80% of people with DLB has delusions. They are very disturbing. Henry's delusion is that his home is not his home. And he has another delusion called Cagora's delusion, where he thinks that his daughter Claudia is an imposter. And when this happens, Claudia always tries to correct Henry, and she says, "Dad, this is your home and I'm your daughter." And then Henry gets angry, and they have an argument. And Claudia gets upset, and Henry gets upset. And this happens on a daily basis. So Claudia seeks help, and she receives behavioral management training. And when Henry says, "You are not my daughter," now Claudia responds, "Yes, I'm not, but she will be home soon. So I start preparing dinner in the meanwhile." She doesn't argue with Henry anymore. They don't entangle in a discussion about whether she is or she is not her daughter anymore, because Claudia has learned strategies to, 1, prevent escalation of conflict. She's also learned more and understands that she should not be trying to use logic, because she knows that a delusion is not a problem with logic. And 3rd, she has learned to redirect the attention to obtain more positive outcomes for both of them. So she has learned lots of things on her training, and even more because she has also learned to do behavioral observations. And with her new skills on, she has noticed actually that Henry is more prone to say, "My home is not my home," when he's bored, sitting by himself without nothing to do. So she has learned that this is called a trigger, and she has been trained to identify triggers of behavior, and she has been trained to modify them. So Claudia knows that by engaging Henry in something he enjoys, as gardening activities, she can stop his delusion from escalating. When gardening doesn't work, because sometimes it doesn't work and delusion escalates anyway, she knows that taking him out for a 10-minute walk around the neighborhood is useful for him to calm down. And that the "my home is not my home" delusion has usually stopped by the time they are back home. Because Claudia has learned also helpful ways to respond to Henry's behavior when she cannot modify the triggers. So all this training is very important for families, it's very important people living with the condition. And I'm going to give you another example, because you may think, "Oh, okay, so this is for behavior and delusions and so how about language? Is there anything that we can do to support people with communication difficulties?" Absolutely. There is a growing body of research evidence proving the positive effects of therapy in PPA. We know, for instance, that people with PPA can relearn vocabulary with a modest amount of training, like, for instance, practicing lists of 20 words, trained over half an hour, 4 days per week. And here in this picture, you can see a homemade training deck with the picture of the word on one side and the word written in the other side. And we know that the gains from this training, from word training, can last months. And we also know, because there is evidence in research studies, that this training can have a protective effect. This means that those words that you train and use more experience a slower decline. And not only that, but there is also evidence that script training works to support people to communicate in daily life. Scripts are short lines of text that you write and train, like for instance, the sentences that you will say to book a table for dinner over the phone. And there is a lot of experience with these techniques, and we know also that people can receive support to practice these skills by video call through teletherapy, and there is evidence that teletherapy can be as effective as face-to-face therapy. That is important because it increases access to support, so it is really worth giving it a go. And I also want to tell you that there is a wide range of compensatory strategies to assist and to augment the ability of the person to communicate and the ability of the environment to support this communication. So I'm going to tell you about Sarah, who is this lady here sitting at the table. Sarah has PPA, and she's here at this restaurant with Tom, her husband. And before receiving training and therapy, Sarah had withdrawn from most daily social interaction because she struggles a lot to get her words out, and she found this very anxiety-provoking. But Sarah has received support, and she has received training, and she has been actually training her scripts. So she was able to make the reservation on the phone for this lovely dinner here in the picture. And something that Sarah also does now is carrying her hidden disabilities lanyard to indicate people that she might need help, and also a card explaining her condition to hand out if needed. So Tom and Sarah explain her needs to the restaurant, and they ask for a quiet table, free from noise and distractors. They avoided going for dinner at a busy time. And they did all that because they've learned that all these are strategies to support Sarah's communication. And they are important for her to have a nice night out and enjoy life. Tom has also been trained himself on good communication strategies. So for instance, he asked Sarah, shall we have fish or meat, instead of giving her a long list of choices. And he also gives Sarah enough time to think and respond. And he also supports his words. When he's talking, he supports his words with gestures to help Sarah understand better. So for instance, he says, shall we order more wine? Or is your food good? So receiving therapy and training is very important to continue having a life, a proper life, and doing the things that matter to us with the people we love and enjoy sharing time with. And with people with visuospatial symptoms. Can we do the same? Because we know that we have these tools for behavior and for supporting communication, but what happens when people cannot see? Because that seems like more difficult, no? There are things that we can do. And this illustrates the reading experience of someone with PCA. I'm going to use it as an example. And this is what many people with PCA report when they start with the first symptoms of the disease, and they say, you know, I'm reading my novel or I'm reading my book, and the lines of text clutter up together and mix together, and I cannot follow the lines of text. Research has shown that reading in PCA improves with visual aids, like using reading rules, using shorter lines, shortening the length of the line, and using a larger space between lines, because we know that these methods help with visual disorientation and with crowding. Crowding is this experience that they have of words and lines cluttering up together. And visual aids, we know more things. Visual aids are also helpful in the environment. So this is a microwave. And many people with PCA uses colored stickers to find buttons, light switches, the bottle of shampoo, and even the plate on the table. There is a massive advantage of using visual cues to support people with PCA. This is based on evidence and recent research studies. And we said before that not only vision, but also other posterior functions and issues arise because of the impairment in the back of the brain. And one of them is apraxia. The difficulties with dressing affect actually 100% of people with PCA, are very pervasive. But there are many environmental adaptations and adapted clothes and tricks that can support dressing, like for instance, these no-tie shoes, or using Velcro or elastics, or many other things. Nowadays, there are very nice adapted clothes. In the past, they used to be probably practical, but they were quite ugly. But nowadays, there are beautiful clothes with all these adapted things, and they are beautiful garments. And these adaptations can also apply and can also be used in other activities of daily living. So plate clips, for instance, are used by many people with PCA and limb apraxia. The clip is useful to stop food in the border, so it doesn't matter that you cannot see the border well or that you cannot use the fork well. You can still enjoy your meal without the food annoyingly ending on the tablecloth. So lots of options here. And to wrap up, I want to mention actually the work of Rare Dementia Support, which is a service specialized in supporting people with non-memory-led dementias here in the UK. RDS is based at the Dementia Research Centre, which is a research department at UCL, and the organization is funded by the National Brain Appeal, which is the fundraising service of the National Hospital for Neurology and Neurosurgery. And becoming a member of RDS is free. And if you become a member, you gain access to the direct support team who can help you with a wide range of matters, from strategies to support the person at home, to safeguarding issues, to navigate the social care system, lots of things. So the direct support team is super good. They are very efficient. And a long list of other services that you can access, everything for free. And this is the YouTube channel, and all support groups are recorded and uploaded here, so you can have a look if you like. And here at the bottom, here is the website of RDS if you want to get in touch. Healthcare professionals can also register, and they are very welcome. There is actually a growing community of healthcare professionals signing up to be kept in the loop of new research and support resources and so. So everybody is welcome. And I think it is time to wrap up now. I would like to, before closing up, I would like to highlight the work not only of RDS, but also the Lewy Body Society in the UK and the Association for Frontotemporal Dementia in the States. I think these three are excellent charities. They have very useful educational material in their websites, and it is something to have into account and to keep on your radar. And thank you very much for listening. I think it is time for questions now.
Thank you so much, Ada. That was really interesting, and hearing about all the different types of dementias. And I think one thing that's so striking, maybe, well, we academics might know that, but I think it's really important to highlight, dementia is not just all about memory. That's maybe what many people might think in the general public, but there's so many other things or symptoms that can come up in people living with the condition. Language, behavior, gait as well. And you mentioned the Lewy Body Society. We've just had a comment from the Lewy Body Society here as well, so they're present. But yeah, it's really opening the floor up for questions, but I'd like to be a bit cheeky and ask you one question first, if that's okay. On a personal note as well, speaking about language and the more language-heavy symptoms of some of the dementias, do you know anything about what's happening in bilinguals? If their language deteriorates? So being bilingual, both of us, is there any research out there?
Yeah, so it's not one of my topics of research, but I do know, I am aware that this is a very interesting field of research, because there is this hypothesis of whether bilingualism can give you some protection, like a slowing decline because you have more cognitive resources. And so what happens typically, what you see in people with dementia who speaks two languages, is that there is difficulties speaking in the language that is weaker in the brain. So, for instance, your mother tongue, it is usually more robust. So we hear a lot of stories and we see a lot of patients whose second language is English. And as soon as the disease progresses, they revert to their original language. So there is an imbalance in the strength of the representation of first and second language in the brain. But there is interesting research about how to support language and rehabilitation therapies in people who are bilingual, because there is some emerging evidence that gains can be transferable. So this is something that it is being investigated, but apparently it is possible that therapies that we are using to strengthen language may have some effect on the second language. It is a very interesting field of research that it is emerging now, with some teams across the world really becoming very strong at this, and more bilingual research is coming up.
Yeah, it'd be interesting what happens to us if that were to happen, being so immersed in the English language for decades then. Yeah, so we've got some nice questions here from the audience. So Peter Lloyd, for example, has asked, to what extent can there be mixed combinations across the discrete subtypes?
Yeah, so there is a lot of mix. It can happen, definitely. And also because as disease progresses, the onset, the beginning is more clear, the clinical picture is more clear, but it is true that as the disease progresses, sometimes someone, for instance, people with PCA, we know that a subgroup of people with PCA, when the disease progresses, they can also develop logopenic aphasia. The clinical profile, they still have PCA, but they start having problems with language that resemble pretty much the profile that we can see in people with logopenic aphasia. This is something that can happen. And also we know that in people with young onset Alzheimer disease, so those people who develop memory-led typical Alzheimer disease, but at young age, they are more prone to also develop features that have to do with posterior affectation. So people with young onset Alzheimer disease, there is also a subgroup that develop visuospatial difficulties quite early on in the course of the disease. So these syndromes, sometimes they overlap and they share many features. And of course, as the disease progresses, then all symptoms converge. So people who are in very late stages of dementia have severe visuospatial difficulties in language and memory and so on.
Okay, and I think, yeah, the language sticks out a bit. We've got a comment by Olga as well. Are there any specific groups or vocabulary, so semantic groups or similar, which are specifically difficult to relearn?
That's a good question. I don't know, because what we usually recommend in clinic, and what it is also what we try to do in the research studies, where when we test therapies, is to practice priority vocabulary. So we know that familiar words are easier to relearn because there are many connections that you can make with those words. The network is far stronger than those that you never use. So I guess that it is more difficult to relearn a low frequency word than than a high frequency word. But in practice, what we do in research and in clinic is to focus on priority vocabulary, things that are very useful to you because you use it very often. So we usually focus on low frequency, on high frequency words that you use, that are very familiar, that have a proper function in your daily living.
Yeah, it makes sense for people to be better able again to communicate with those really priority topics. So you've got some positive feedback from Lewy Body Society and from others in terms of the training that the society provides to carers or people living with Lewy body dementia. They give the same advice that you've just given in your talk, so that's a positive reinforcement that there's the similarity. Also talking about carer training. Oh yes, so I don't know whether you know about work in care homes as well, or whether it's more in the community or setting non-specific, but someone's asking how far is there carer training in care homes that includes these insights about different dementia subtypes?
Sorry, you broke up a bit. So is the question whether I know how well trained, how good is the training, the specific training that care home workers receive about it? I don't know. I don't know. I think it probably varies a lot. Probably I think that there are care homes who perhaps have welcomed a few residents with this type of dementia, and perhaps they've decided to organize a specific training because they had a few cases, and perhaps in another care home there is only one person, so they are less aware. But that's really a speculation. I'm not. Yeah, I don't know. I'm not in a position to respond how good is the training in care homes.
No, that's fine. So if we move a little bit, sorry about if my internet breaks up, that's very unfortunate timing. If we move on from the language focus, so we've got a question from Joan. I don't know whether you know, Aida, but what therapies are useful for gait and balance? Do you have any information on that?
So I think that's probably more the field of physiotherapists and other kind of professionals. Unfortunately, it's not a field that I know that well. The kind of therapies available to support someone with gait difficulties. People with DLB receive medication for their movement disorders. So that is the first line of action, actually, the pharmacological one. But beyond that, I think that that's more probably the work of physiotherapists, and I'm pretty sure a physiotherapist will be in a better position than me to respond to that question, because I haven't worked directly on the physical rehabilitation of people with DLB.
Mm-hmm. No, that's great. So it's kind of highlighting also the multidisciplinarity of people that are involved in supporting people with rarer dementias. So we've got a few more comments here. I'm just picking up anonymous comments. So this carer is talking about her partner having been diagnosed with PCA 4 years ago. But she's also talking about how can the response of the rare dementia support outside of London maybe be more focused on rare dementias. So I assume the person is not very London based. Do you have any thoughts on that, Aida?
Yeah, but sorry, I should have made this clear. You can receive support from the direct support team by phone and by email. So it's not only for people based in London. This is a UK-wide service, and we actually not restricted to UK because there are members from other countries like Australia and the States. So you can sign up as a member, get in touch, and you can receive a lot of support. You don't need to be in London, and it doesn't need to be face-to-face. And also they can put you in touch with local PCA support groups because they have a list of all the support groups across the UK. So they have access to a lot of resources, and many of those groups have been set up by members of rare dementia support themselves. So they can put you in touch with a network of resources and many other people living with PCA, many other families, many other local support groups. So it's definitely, I encourage you to get in touch. It's worth it.
Great. And maybe one final question, unless there are more coming in. So you've talked about what's happening in the brain as well, and what's affecting different types of dementias. And you talked about different strategies and how people living with these different conditions can be supported. What about services and resources? So someone's asking here, in their experience, people with rarer dementias might not want to join or engage with traditional types of service and support, such as daycare. Do you feel that the services they would like are out there for them to access, or does something need to change?
Oh no, there is very little support for people with non-memory dementias, very little support and very few specialized teams, because they are low prevalent, so they are not that frequent. So when you look at the people seeing in a cognitive disorder clinic, the majority of them have typical Alzheimer disease, so the resources available there are many more resources for people with typical Alzheimer disease. And for instance, for people living with PCA, because it's so low prevalent, there is almost nothing. It's completely an empty landscape. So this needs to improve, but also I think that services will need to be better coordinated, because realistically you cannot have experts in PCA, for instance, or in semantic dementia everywhere. That is not going to happen, but you can have a few hubs in the country that are very well coordinated and can cover the needs of all the patients. That is something that should happen and could happen, definitely.
Definitely, and yes, that's something that sadly comes up still when we do research, that services don't seem to be targeted, which is missing out providing that much needed support and that individual support for people as well. So I think that's all we've got time for. There are a few more comments from carers. Ida, if you want to look through them afterwards. And I think thank you to everyone also for sharing their experiences here in this chat and raising those issues. If you wouldn't mind moving to the next slide, Aida, please. Great, thank you. So just a little note for the next webinar in March on the 30th, again from 1 till 2. It'll be virtual again, as usual. And we will have a talk from an Admiral nurse from the Isle of Man and a dementia care navigator from Mercy Care, so up north. And they will both be talking about dementia care after diagnosis. So how can Admiral nurses and dementia care navigators help? And usually dementia care navigators are not that well known, so it'll be really interesting to hear how both of these roles complement one another. So as I said, I've shared the link in the chat, but it's also on the screen, and that's us. So I really just want to take the opportunity again to say thank you, Ida. Thank you very much. And thank you all for listening. Bye now.